Okay, good morning, good evening, good afternoon. This is Dr. Garais, BIO112, and tonight's lecture is Chapter 11, and it's a continuation of our neuroanatomy. So we already know the central nervous system. We call it the central nervous system, not because it's in the center of our body, because it is the center of homeostasis. If anything happens to my either brain or spinal cord, there is much chance for loss of life or loss of massive function as compared to peripheral nervous system. Peripheral nervous system, I pluck out one of your spinal nerves, or I pluck out one of your cranial nerves, or maybe your nerve in your arm or your foot. You're not going to die. But if I have any pathology in either the brain itself and the spinal cord itself, there is significant, your patient will be in significant danger. So remember, central nervous system, brain and spinal cord, and not because it's in the middle, it's because it's the center of it all. And we already know that in our first chart that we went over, chapter 1, when we looked at how homeostasis works. Now, the brain and spinal cord, as mentioned in the laboratory yesterday in anatomage, they're sterile. Meaning, is there any virus, foreign body, bacteria in there? No. Unlike the skin, your lungs, your heart, everything else has stuff in it, except the brain and spinal cord, because it's very, very sensitive to that stuff. So you have these three-layered membranes or coverings of your brain and spinal cord, and that is called your meninges. The meninges, there are three layers. You have the outer dura mater, arachnoid mater, which is the middle, and your innermost layer is the pia mater. Mater in Latin means mother, so dura is what? Tough. So the tough mother on the outside, the mother or protecting your brain, it's tough, it's dense. And then right underneath it, you have the epidural space. And then right underneath that, you have the arachnoid matter. We kind of mentioned really briefly Wednesday's lecture, when we talked about cerebral spinal fluid. Cerebral spinal fluid is very important because it's the communication between your brain and spinal cord. There's a lot of ions, nutrients, oxygen, carbon dioxide. And as just a little side note before we even get to our pulmonary, your brain doesn't really monitor oxygen. It monitors carbon dioxide. And where's that carbon dioxide actually monitored in? It's monitored in that cerebral spinal fluid. So if you get anything in there like a virus or whatnot, and we already talked about in lab how dangerous meningitis is. And if you have a patient that has meningitis, right, no matter whether it's bacterial or viral, don't be in that room longer than you need to, and follow your protocols. You got to glove up, you got to put the little booties on, and even if you're in scrubs, you better put on the disposable, right? And also, not only mask, you also have face shield, even if you're going to talk to your patient for a minute, because meningitis is very, very it's very communicative. You could easily get it. And let's say, for example, it doesn't hit you. Many of us have high-risk people at home, have older people with lesser immune systems, younger people with lesser immune systems. I have several cases of the nurse or the doctor didn't get the meningitis, but who got it? The kid at home. It's also a nice little practice that I have, on my scrubs and actually my work clothes. It's just a habit I had from the hospital from years ago. I have a separate hamper and bin for it, and it gets washed in a separate system. Like all my kids and all my family's clothes get washed upstairs. Mine gets washed downstairs, with the rugs and the other unwashed things in the house, and it's for a good reason. Not only because my wife's a little bit psychopathic and neurotic, but it's a good practice because if I get exposed to anything. Nowadays, You can't, in a lot of bigger facilities, you don't wear your own scrubs. You go in every day and you get them from Central Supply. It's like this big vending machine thing. And then at the end of the day, do not go to the mall with what you wore to work. You take it off and then do what? You throw it in, there's these big yellow or white biohazard, you put it in there, and then you wear your street clothes out. So that your street clothes, even, I don't know why we're focusing on socks today, even your socks and your shoes, that all stays what? In the ready room. None of it goes in the hospital proper, in the ward proper. And especially if you're in a very sensitive place, like, what's really sensitive? NICU, any cardiac care, any ICU. There's a room before a room where you have to glove up, do all that other stuff. Infectious in internal medicine as well. Okay, so you can see how important our central nervous system, dura mater, arachnoid mater, pia mater. And of course, it runs by that theme that we always talked about. Anything that's on the outside is what? Tough, hard, connective tissue. Everything on the inside is very delicate, light. So if you look at the pia mater, the inner layer, it's attached to the brain, and that's where it has all the blood vessels, all the nervous system, everything that nourishes your brain and spinal cord. So you can see how you got to go through 2 layers just to get to what? The really good stuff. And the really good stuff at the level of the pia mater is very, very delicate. And I also mentioned yesterday in lab, we talked about something called the blood-brain barrier. Well, it is at that level when you're already there. The blood-brain barrier isn't like an actual barrier. It's actually a chemical barrier that, just like your plasma membrane, you know, that bilipid membrane of all the cells, it allows some things in and some things out, and it protects your brain from. And one of the things that it definitely shouldn't let in is viruses, bacteria, and any foreign body. That's why if you crack your skull open and there's an open connection, or if you're leaking out any cerebrospinal fluid of your nose or your ears, especially with blunt force trauma, the emergency department gets really excited about that. So we looked at here, we kind of saw this yesterday in lab when we were looking at the different sections, but you could see here that, of course, you have the skin and stuff, and then you have your pancake, your flat example of a flat bone, which is your skull. And just like, you know, the carbon fibers of a high-end race car, or the carbon fibers of a $10 million jet, it's made out of carbon. It's very, very light, but very, very strong. And your skull is no exception. And of course, we talked about remodeling this, like you bonk your head, what's going to happen? The osteoclast will do what? Break down the damaged bone, osteoblast will start growing, and then to make osteocytes, mature cells, so that it can, it can make the bone stronger. And remember sutures, you see this right here, syndesmosis, or suture is an example of a type of joint that doesn't move. So your skull, once it's all grown up and fused together, it shouldn't, it shouldn't leak anything through. So you can see that there's multiple layers even before we get to the meninges to protect us. And then you could see the meninges it's not only covering the brain, it goes down and covers the spinal cord as well. And if you recall, looking at the mid-sagittal section of the anatomage, remember how you had the cranial cavity? It's actually continuous with the spinal cavity, and you can see here. So all that fluid, that's your cerebrospinal fluid. And the dura mater is on the outside, the pia mater is on the inside, and in between you have this, and they call it arachnoid because it looks like a spider web. So oid, resembling, arachnid means spider. So there's like this spider web of material in between your dura mater and your pia mater. Remember, dura, tough. Arachnoid in the middle, that has the cerebrospinal fluid. And what's so special about the pia mater? That has all the blood vessels. So if you get bonked in the head hard enough, right? If that force of trauma affected all the way to the level of your pia mater, don't you think you're going to start bleeding? If you start bleeding, don't you think all of that all that blood might start filling up all of this? Yep. Now, if that blood starts filling all it up, what's going to happen to the brain? It's going to get squeezed, and we already know the brain and the brain and nervous system is like a wire. It has electricity and chemicals running through it. The last thing I want to do is what? Press on it. So when there's an intracranial bleed, right? Intra, in between your cranium, right? So if blood starts filling up here, and that's a problem, isn't it? And that's why we get very excited for any blood force trauma, even though, you know, I told you about the lady bonked her head, right? Everything was all cool. It was just a little bump. And then you asked her a judgment question because that affects the frontal lobe. And I asked her, hey, if I dropped a $100 bill on the floor, what would you do? And we all know the classic answers. Oh, I would take it, or I would give it to you, right? And then she looked at me with the straightest face possible and said, I'd eat it. And I go, you do what? And he goes, I'd eat it. Oh, by the way, all the other things were okay, but she was slow to answer. There was a little bit pause when I asked, what year is this? She was like, 1990, 8 or 9. No, it's 9. And I'm like, okay. And all the answers were okay. But then when I asked her that question and other questions, when I asked her a mathematics question too, she started answering me not in numbers, but in letters. So does that mean what? When she hit her head here, later, what did we find, right? She started having ins and outs of consciousness. What did I find? When she hit her head, there was a slow bleed. So, and that's also the reason why we keep you in the hospital. Even if you can answer all the questions all good, I like keeping you anywhere from 12 to 24 hours, because if there's a slow bleed, we're going to start seeing it. And that's also one of your responsibilities regarding patient care. If we're watching somebody overnight and I'm telling you, hey, check on level of consciousness Q1. Every hour, that means what? Every hour on the hour, you will do your Glasgow Coma Scale. Not every hour or if they look okay. How many times I've lost somebody at 2 a.m., 3 a.m. because why? Medical staff thought, hey, looks okay. But you could see here, is there a lot of space here? No. So even 20 cc's, 30 cc's of blood will do a number on this. So something to look out for. And those are the 3 thick coverings, and that's underneath your skull. You can also see now, okay, my brain and spinal cord is surrounded by this very important cerebral spinal fluid. Now when you think about surgery, brain surgery or spinal surgery, doesn't that complicate matters? Because remember what we stated? The brain and spinal cord is sterile. The second I drill holes in there or I open you up, what happens to the sterility of it all? You'll be severely compromised. And that's why a lot of neurosurgery survival rates are in the 40s. No neurosurgeon wants to tell you that, do they? Survival rate, something like 44%, meaning what? Out of 100 patients who have have neurosurgery, 66 of them probably will die, or will have such complications that it will lead to their death. Because if I have to open this up, there has to be a really good reason. And you can see now there's so many layers and so important to protect my central nervous system. My central nervous system has these little aqueducts, or they're called ventricles. You have 4 of them, 2 on the side, 1 up top and 1 on the bottom. So the 1 up top is your 3rd ventricle, the 1 on the bottom is the 4th ventricle. And remember the term foramen? Foramen just means hole. So foramina is the plural of holes. So there's a whole bunch of interventricular holes. So your ventricle, right? Those are just spaces in your brain. And you have foramina and aqueduct. You don't need to know which is which. Just know that there are ventricles or rooms in your brain. And we saw some of them when we were looking at the brain yesterday, where there's going to be a kind of like a river system of flowing cerebral spinal fluid. And what cells make cerebral spinal fluid? According to that picture that we had on Wednesday, who's guarding the kiddie pool? Who's surrounding all the kiddie pool in that picture? It was in the upper left hand. Remember the kiddie pool, right? You see what it looks like, right? Well, think of this kid. His name is what? Epstein. So that's what? Ependymal cell. I don't know why I remember that, but it's a skinny kid guarding. In my mind, he's guarding a kiddie pool. The kiddie pool, can we urinate in it? No, it has to be clean because cerebral spinal fluid is sterile. So it's the cleanest kiddie pool. Are there kids in this kiddie pool? No. All right? And who guards it? Who's the lifeguard? That's Epstein or whatever name you can give him, but that's what? Ependymal cell. And to me, in my head, it's Epstein, so that's ependymal cell. And from that picture, right? How about who's the one who gives in the lower right hand, and he has a yellow striped shirt, and he was giving and we're in the central nervous system, and it was giving the neuron or the nerve cell their fat, or those hot dog rolls of fat. What was that? Central nervous system. To me, in my head, is some kid, and he's fat, right? He's wearing a yellow striped shirt, and his name is Ollie, oligodendrocyte. So play these little games with yourself, because these words are not English, and they're odd, and they're weird. So now you know Epstein, right? In the upper left-hand corner, he's going to keep the pool what? Clean, and they're going to make the fluid, and that fluid is cerebral spinal fluid. So ependymal cells line a lot of these ventricles, especially your ventricle up here, right? And the ependymal cells will make cerebral spinal fluid, because the cerebral spinal fluid is what? It's constantly circulating, because remember, what's its function? Its function is the way our blood communicates with our whole entire body with oxygen and carbon dioxide. It does the same thing for the brain and spinal cord, right? So if you run out of cerebral spinal fluid, that's a problem. If you have too much cerebral spinal fluid, that is also a problem. Remember the story I told you why I hate peds, right? I had a patient with little girl with hydrocephalus. Hydro is what? Water. Cephal, your head. Because her brain was making way too much cerebral spinal fluid, what happened to her head? Blew up. And then when it blows up, what happens to the pressure? It presses on her. For the first week, she was talking fine. At the end of it all, the only way she could communicate was like this. She would physically scratch when she wants to eat, when she wants to defecate. And she was, what, 10, 11 years old, something like that. And I just, because the fluid is so important, you can't have too little, you can't have too much, and it communicates. And you could see it communicates all throughout your brain. And then, of course, you can see down here, then it strolls into your spinal cord. So the ependymal cells are all bunched up, and we saw them on that picture. Remember, they were all lined up on the edge of the pool, right? Epstein. So that's called the choroid plexus. And that's, of course, in the pia mater, because the pia mater has all the what? The sensitive stuff. Capillaries, and guess what? It has what? Epstein and the choroid plexus, right? And they make cerebral spinal fluid. And cerebral spinal fluid is protective. It's nutritive. That means it'll do what? It takes out the garbage, and it also provides oxygen. It provides nutrients. And remember, what are the two main things that great, I gave one away. What are the two things that your brain loves to eat? There's only two: oxygen and glucose. You don't get either. You get loopy, don't you? Right? Anyone ever had like any oxygen deprivation? Maybe you were in a plane or whatever. None of y'all ever like ridden one of those little planes that went with a little prop? Oh, That's real funny. Last time I jumped out of a Fokker 40, there was bad weather, so we had to go a little higher. And when you go a little higher, how's the oxygen? When you go up above Angel 16,000, it gets what? It gets real thin, right? So the only people who had oxygen were what? Pilot. So everybody in that bay got what? Loopy. No oxygen. Everyone started acting silly and goofing around, right? Now we also know what happens to us when we don't get glucose, right? Just like the commercial. You're not you when you are hungry. So if you're fasting more than 14 hours, what happens? You get either loopy, funny, hyper irritable, right? And then your personality starts changing significantly. So those are the two things that the cerebrospinal fluid not only communicates, it tries to keep it within that system, and it circulates, so it goes round and round and round. Okay, and it's about 140 cc's, give or take, and this is based on a 70 kilogram meal. So remember, epidermal cells, choroid plexus, cerebral spinal fluid, and that's really important stuff. And you can see here, it goes round and round. So not having a lot, that's a problem. Having too much, that's a problem. You need just right. And you can also see here that if I get bonked on my head, any blood gets in there, or any foreign body gets in there, that's not good. Be very, very wary of anything leaking out of your body that doesn't smell, that's clear, and it's kind of like serous fluid, but it's not as slippery. If someone gets in an auto accident or whatever, and stuff's coming out of their nose or their ear, and it's clear. Be very careful of that. I had a colleague of mine who mistaken on a 9-year-old boy. He had, I don't know, something happened here, and then throughout one of his sinuses here, I don't know, basal fracture or something. Then it started leaking cerebral spinal fluid. He let the kid go with like a couple of antibiotics. 6 hours later, he goes, I now had the patient and kicked the kid up to ICU. And then I looked, hey, he was in our ER about 6 hours ago. So I went to the doctor who released him. I'm like, you wrote down rhinitis. And he goes, this kid has a cracked skull with CSF leaking out of his nose. And he looked at me in great fear. Why? He messed up. He did what? Just assumed, oh, it's just, right? And that's a problem with trying to see your patient fast, right? To try to get through the day. Well, you might miss something like that. Well, that's kind of scary. You can see here, it connects all the way down to what? Your tail, your coccyx, right? So it's dual function. It's nutrition, and it's also protection to your brain. Now, how so? Just like, you know how baby is in their little fluid pouch, right? So, of course, don't punch mommy or don't kick mommy, but you could, right? Not saying to do, I'm being recorded. I'm not saying to kick mommy, but if mommy got any trauma, baby would be what? Semi-protected, because baby is floating in water. And if you see here, your brain and your spinal cord is floating. So if something hits you, right, the shock wave should, if it's not too bad, should be absorbed by the fluid and all the surrounding bone tissue. But here's the problem. If the shock or the trauma is significant, right, don't you think I could get hurt here and then the brain can slosh over to the other side and then get hurt on the other side? It can, but that requires like something really big, like, you know, let me use an example I used in another lecture, like a UPS hitting your head, or a bus hits your head. It would require something of that level. But I've seen it on, no, I actually haven't. I had a couple of kids got in a fight, and one of the other kids hit the other kid with like a metal bat, an aluminum bat, like a couple of times. There was no, what they call contra coup injury. There was no injury on the opposite side, only on the effect. Brain. We already know what the brain is, okay? It is the center point for all homeostasis. It processes, it analyzes things. So back to what I stated before, and it seems like your class is pretty at least psychologically, you guys are pretty centered. Because usually when I say everything that you see and hear is not real, people are like, no, no, you know, then we have a debate. But you guys are pretty cool with it. So you guys are okay with, you know, living in the matrix. And what is living in the matrix meaning, right? Everything you hear, you see, you touch, you feel, because that is your reality. It is the reality dictated by your brain, right? Like I stated, I'm gorgeous in real life, but your eyes are picking up something else, and your brain is doing what? It's changing it. It also has higher mental functions. And remember, memory, reasoning, all of this is not only electrical, it is chemical, right? So if you get zapped, that's going to be, with electricity, that's going to be a problem. And of course, if you put chemicals that shouldn't be in your body, that's going to be a problem. Coordination for muscular movement, that makes sense because it controls the efferent. Visceral activities as well, because that's automatic. And look here, your personality is what? Chemical / electrical. And that's why the Department of Psychiatry and Pharmacology trying to change that. Your brain development. There's 3 parts. And we talked about how organs, like how cells become tissues and tissues become organs. Remember, I made the analogy that it was like origami, right? Like you take sheets of cells and you start folding them. And that's what's going on here. And it starts out like a tube. Now, if you recall, the brain had two sides, right? A left and a right lobe. When you use your imagination, don't you think it could be a flat piece? And then you could do what? Roll it like this, and then you'll have a left side, and then you have a right side. And then, you know, I guess the bumps start forming in the same exact way. So you have a forebrain, midbrain, and hindbrain. Now, all of this is academic. You don't really need to know this, but just know that a lot of your body forms in these. And you see when I do this, does that look like an arch? Right? How it folds. When you fold something over, it's like an arch. And that's why you hear some things like, if ever you take a development class, which I highly do not recommend, like you'll hear something called the Splantic Arches, where that's how your forebrain, your midbrain, and your hindbrain get formed. And then it makes cavities. Then your forebrain becomes everything in the front, which is your cerebrum, and your mesencephalon, midbrain, that's everything where, like on the deep inside, and your hindbrain becomes everything in the back and all the way near your spinal cord, which is your cerebellum, pons, and medulla oblongata. So think forebrain kind of on the top, midbrain in the middle, and then your hindbrain is like everything that's coming closer towards your spinal cord. And I could show you that in a better picture like this. So when you look at this, right, you have your forebrain, that's like everything that's up here. Then midbrain is like here, and then your hindbrain is like back here. So it forms layers. And this is a lovely picture, and we're going to talk about each and every one of these things. But let's look at some of these parts. We already talked about some of these parts. Remember, the ridges or like the grooves are called sulcus if it's singular, sulci, S-U-L-C-I if it's plural, and the bumps, that's gyrus, gyri if it's plural. We have here the corpus callosum. We saw that, and this is supposed to be the white matter, and this is supposed to be the gray matter. And remember, the difference between white and gray matter is that the white matter's got a lot of fat. It's got a lot of myelin. So that's all this stuff here. Now, the gray matter has less myelin or less fat. So you have stuff like this area here, that's your thalamus, your pineal gland. Some people say it's a vestigial gland, but your pineal gland, well, the lecture is going to talk more about it, but it has to do with your sleep-wake cycle. You know, like when you get, well, we're all night birds because you guys are taking the evening class, but you guys know that once you shift, or maybe you get jet lag, don't you feel like a little weird? Like if you get jet lag, like you feel day is night, night is day, that kind of thing. and it's because of your pineal gland. Hypothalamus, right? If this is your thalamus, right underneath it has to be the hypothalamus. You have your anterior and your posterior pituitary gland, and when we talk about endocrine, the pituitary gland is the master gland, or the one gland to control them all. You have midbrain here, pons, your medulla oblongata, and then your spinal cord. And all throughout here, see all these spaces? That's what? Cerebral spinal fluid. And this here is your third ventricle. Your cerebellum is here. And same exact picture, but this way. See, look at this beautiful pro section. It's like this is almost not real life. I don't know where they got this from. This is really great. This is nice. But I have a sample of that. Or I could take this one, erase all this, A, B, C, D, E, F, G. I could easily do that. But I won't. I like pictures. And I have a picture momentarily. So the cerebrum, the largest part of your brain, part of your proencephalon, or your forebrain, or the first part of your brain. So it has two halves, right? You have your left side and your right side. And we mentioned in lab, which one? I forget which one layperson's called. The left side is the artistic side. Which one's the artistic side? And which one's the mathematical side? Just know and understand, because of the corpus callosum that connects both sides, artistry and mathematics, or analyzation and intuition, they're both connected. Because when you think about it, when you have intuition, like when you're looking at somebody or something and you're like, oh, I think that person's viral, has a virus. Well, it's because what you're seeing, what you're hearing, and what you're processing, and there's a mathematical portion of that, and there's also an artistic portion of that. Have you guys ever been to Howard University? There's this huge building on the west side of it called the Medical Arts Building. There's a reason why they call it the medical arts, because many times, especially when we're doing management and diagnosis, you got to be kind of creative. And as future nurses, you're definitely going to get creative. Gyri and sulci, and a fissure is like a deeper groove, and we're going to show you like the separation, the mid-sagittal fissure, which is the separation between the left and right hemispheres. So corpus callosum, connection between the two. Sulci and gyri, gyrus, or gyri plural, ridges, and the sulci, that's the grooves. So we're looking at this. It's a beautiful picture, which I also have for our sample quiz today. Of course, if it's in the front, frontal lobe. Behind the frontal lobe, and I wonder if you guys noticed yesterday that there was this one part of the brain that was, the gyrus right here, part of your central sulcus. Did you guys notice it was like a little bit fatter? And you can kind of tell, like this was the front part and this was the back part. And we'll take a look at it more deeply when we're looking at the anatomy in practice. But the frontal lobe, front, the pair of parietal lobes, just like you had a pair of bones in your skull. Occipital lobe, of course, in the back, and your temporal lobe here, which is on the sides. Okay. So those are the 4 lobes, and then you have this thing, which is your insula, which is lateral sulcus, island of Real. I want you to focus on these 4. So let's look at what these 4 do. Wait a minute, why are they just jumping to? Let's see, did they? Oh yeah, they eventually get to it. They're messing with us. So we know it as cerebral cortex, and we know that the cerebral cortex, or the main part of the brain, which is the top part, that's made up of a lot of gray matter, right? But it is the white stuff, all this stuff here, that's of course white matter, and that is because of their myelinated axons. It's the worst I'll do you. So cerebral cortex, or this part, right? Top part. That has a lot of higher mental functions. And remember we talked about all the lower mental functions like breathing and heart rate, blood pressure and all that. That's where? That's deeper. That's already in the hindbrain. Because whoever built us said, hey, I can lose some of these higher functions if I need to live. Like you can live without some of this, right? And there are a lot of pathologies that have all of this. But you could see that the cerebral cortex is kind of important for all the higher mental functions. And that's the reason why we ask you specific questions on a mini mental status exam. We ask you to do really quick basic memory and basic mathematics, how to retrieve, and of course, what would you do with a $100 bill if I dropped it on the floor question, reasoning, and the seat of intelligence and personality. Yeah, let's look at this. This is beautiful right here. So, of course, we already know the frontal lobe. Concentration, planning, problem solving, judgment, all up here. Let us look at this. The temporal lobe that deals with auditory patterns. And doesn't that make sense? Your hearing, your temporal lobe is where? It's here. Where are your ears? Here. So that's auditory. Your parietal lobe, right here is, right here, area 1, 2, and 3, which is your motor control, and then you have your sensory here. So your parietal lobe is the coordination between your motor and sensory, because we all know sensory sends up signals to my brain does stuff, and it makes sense. My brain will then send messages to my motor. So if I sense I'm cold, right, it goes up to your brain in that area, and then it's nice. It came up here, right, for motor, and then I have a signal going straight down, telling me, oh, go shiver. And that's parietal lobe. The occipital lobe, think visual image, visual recognition. I told you guys the story about that same patient, the one who bonked her head. When I gave her my pen, right, she started getting a little loopy 4 or 5 hours in, and she was still in ER. We still didn't bring her up yet. And I wanted to do a little bit more an expanded mental status exam before Neuro got there, so they can have more data. So I don't know. I was just being a little bit neurotic. I gave her the pen, and she did what? She was like, she couldn't tell me what it is. She knows what it is. I could see it in her face that she's recognized it as what? Something that she knows. But because remember, it has to do with visual recognition of object. That means what? That part of her brain is also has a problem, right? So that's what back here. So anything to do with your vision, that you're seeing something and recognizing something, that's there too. And so you got the temporal lobe, the parietal lobe, occipital lobe, and your frontal lobe. Those are the 4. Of course, your cerebellum, we're going to talk about in a minute. And of course, your lower functions, which are the really more important stuff, that's not more important, but the stuff that keeps you alive, like your heart rate and blood pressure. You have other things here. You see this Wernicke's, and you see here Broca's. Wernicke's area and Broca's area have to deal with speech. And if you have issues in either this area or this area, you may have aphasia. You won't be able to speak, or you want to say something but don't know how to say it. So Broca's, Wernicke's, think speech, and we know all the others, right? All the other 4 lobes: frontal, temporal, parietal, and occipital. Parietal area, we already know sensory speech, Wernicke's, right? Think what? Speech, Wernicke's, Broca's. Visual area, occipital lobe back there, interprets vision. Remember, I have to tell you, interprets vision. So could you be mistaken about what you see? Yes. Or um, could it also be a potential source for a hallucination? Yes. Same thing with auditory. Temporal lobe, it interprets your hearing. Have you any of you guys ever seen those memes? I don't know, it's on Facebook or TikTok or whatever, where they play a sound bite, right? And then they say, it'll sound like whatever line you're reading, and it's like 9 different sentences or 9 different words. And then whatever line you're reading, that's the thing you are sensing. Because what are you doing when you read something? You're already doing what? You're looking at it, your brain starts interpreting, so it's already setting you up for your temporal, which is your auditory area. Sensory area for taste. Now, the insula, I want you just to know where the area is. Your brain is separated into the left and right, but there's a space in between your left and right hemispheres, and that's the area of your insula. But just know taste, smell, and all of that, think what? Sensory, think parietal, okay? That's where taste, smell, and all that. So if I have a parietal problem, you think I might not be able to taste something. Yeah, I might not be able to smell something. Parietal lobe, temporal lobe, yeah, just kind of saying the same things. Broca's area. Broca's, again, big speech. Frontal eye field. It's not the same as occipital. The occipital in the back is the interpretation of what you see. But the frontal eye field, which is in your frontal lobe, that's the thing that tells that allows you to have the ability to, look up, down, left, and right, and also to coordinate it. And I'll also show you in the special senses lecture how we actually do that, and also actually why. Didn't you ever wonder why your eyes move the same place? All right, right, and maybe you guys heard of the blind spot. It goes back to what I was saying. What you're looking at, is this exactly what's happening out here? No, what you're looking at, what you're experiencing right now, is your brain's interpretation of what's going on. It might not even be what's going on. And that's why magic works. You ever watch people magic on stage, right? When it's happening to you, I was in Vegas and they called me on stage and then they did the pickpocket thing, and my wife videotaped it. I was like, man, I'm from New York. You're not pickpocketing me. And, he goes, and they kept on doing what? He kept on touching me in like weird spots, and I kept on going, why is he touching me? Because what was he doing? He touches me here. My sensory is not focused on what? The thing that he's touching me. Then he undid my belt. And he was like, oh, you're missing something? And I'm like, dude, I go, this stuff, there could be problems, right? But hey, it's Vegas, right? And then he got, he noticed, like, he goes, oh, I noticed you're not carrying your wallet. And I go, no. And he goes, oh, but you have mine. I'm like, and he put something in there, right? And it's because when I rewatched the video, I saw what? He's touching me, then he's turning around. Turn over here, it's better here in the light. And he's moving me around. And what is he actually doing? Right? He's distracting me. And also the same thing with magic. But magicians now are even smarter now because they know that everyone has cameras and stuff. Some of these illusions, and I'm one of those people who because I'm a person of science. Well, except for my belief in the poltergeist, right? I'm a person of science, so when I watch magic, or if I watch a card trick, I'm the first person to look it up on YouTube. I know, that's horrible, isn't it? It's like why can't I just believe Santa Claus is real and just move on with my day? No, I'm a person of science, so I want to know how it's done. Like for years, I was practicing how to palm cards, right? I just thought that was really neat because our eyes tell us what when they start doing that. Hey, the card is disappearing. How did you get the ace? Nothing up my sleeve. But what are they doing? They're palming it in between here. And what are you seeing? You're only seeing what? What's in the front, but not what's in the back. So your brain is interpreting that. Now, you have dominant and non-dominant hemispheres. It's also the reason why there are righties and lefties. But like I always stated, anyone here is from a Spanish or Latin culture? It goes, look at your grandparents. They were only taught how to write with their right hand. Because why? These crazy Catholics in the 20s thought that what? If you write with your left hand, the right hand is called your, what is the right hand called?
Spanish?
No.
Oh.
Latin. Well, the left hand, I know for a fact, is the left side is called sinister, right? Well, you know the word sinister. It's like what? Sinister. It's evil, right? So when we're doing shorthand for left eye, it's OS, and the shorthand for right eye, jeez, I forgot my ophthalmology. What was it?
Manus dextra?
I don't know what that is.
Right hand?
Oh, well, dexter. Thank you. So OD, right? If you go in ophthalmology, is what? Dexter, oculi dexter, which is what? Your right eye. OS is oculi sinister, meaning what? The evil eye. So this one's the evil eye. Well, my grandfather was telling me that they used to get whipped because he's from Spain. They used to get whipped if he used his left hand. He's lefty, right? So he learned how to do what? Both. So he was in front of his teacher. He's like, hey, I'm good. Look, I'm going to heaven. And then when his teacher came out, he's like, and it was really good, interesting because why? When he was in his 70s, he got a stroke. And since he's, right, he's ambidextrous, the stroke did not affect him as much. And then later years, I found that actually that's a good thing to always work on your non-dominant side because it's a lovely anti-stroke protection. So that's my new thing now. Like when I go driving for a long time, I always do what? I kind of consciously, I'm going to use my left hand. I don't want a stroke, right? Or if I'm brushing my hair, I go, hey, I'm not going to get a stroke. I've been doing this for like 2 decades because the dominant hemisphere, you have dominant and non-dominant hemispheres. But of course, what happens if you train? What happens? Like this won't be the greatest hand because I'm righty, but what will happen? This one gets much better. Actually, my left arm is stronger than my right. Because why? Because I've been for the last 2 decades I've been obsessed with what? The left side, right? My non-dominant hemisphere. So you look at this, of course, language, verbal, analytical, right? But know that because of the corpus callosum, the connections, there has to be a connection. Non-dominant, think what? Non-verbal, motor tasks. Think the other side. So the non-dominant hemisphere, that's the musical, visual, and artistic. And just like when people say to me, I'm a bad test taker, when people tell me I'm not musical, because no one ever let you be musical, or I'm a bad artist. You're a bad artist because no one trained you. No one trained you to be to draw and stuff. I used to actually hate art class, but now I immensely appreciate it because every once in a while, I go when I doodle and stuff like that. And I remember in college, I had to take a theater class, and then it led me to take a class like what do you call it? Like an arts appreciation class. Just imagine if I never took that. I would have never been to the theater. I would have never known because when I was younger, I always thought like, oh, that's fruity, or oh, that's not manly. You know what I'm saying? Like, you gotta admit, I grew up in like the 80s, so everything was like, you gotta be macho. You can't watch a musical, but then you appreciate it, and it's art, just like the theater, just like everything. When I was the place that I grew up in, been a musician all my life. I played trumpet when I was a kid. You gotta hide that, because how many times kids took my trumpet and messed with it and did all these horrible things to it. When I think about it now, it's kind of funny, right? But your non-dominant and your dominant have to kind of work together. And if you ignore one side, I don't know, it's not sad, but it's good to work both. Now, knowing and understanding this, why do you think, those of you who are CNAs, don't you think don't you think it's part of your job now to force your client to go to the musical thing, go to the karaoke night, go to these things, not only for social reasons, but for what? Stroke protection. Right? And especially as a CNA, your clients are very, very lonely. It's a very, very lonely existence a lot of your clients have. So forcing them to do some social stuff and get them out, it gets them, some of them get so rambunctious and get so upset, but at least they're what? You know, they're active. Because imagine just sitting in your chair all day, that would make me nuts. Now we're delving into like the inner parts of the brain, or the more what they call the lower functions. The higher functions, think what? Mathematics, judgment, so on and so forth, right? But now we're delving into the middle and lower parts of the brain that that deal with all this stuff: thalamus, hypothalamus, like endocrine stuff, and homeostasis. Always think hypothalamus. Always think homeostasis. So it's in the middle. So what does the thalamus do for us? Right now, there's a lot of stuff going on. Your brain is picking up a lot of stuff. How's your chair feel?
Hard.
Now that I mentioned it, now you're like, ah, man, right? Your nose also is picking up every single scent in this room. And like I stated, your eyes, you're picking up every little pixel of every little thing. But of course, you're not focused on that. You're focused on what? Well, whatever you're focused on. And your thalamus does what? It's sort of like a filter, right? Okay, I'll buy that. Really, when I was sitting in your chair, I wasn't totally focused. So the thalamus is the gateway, and what does it also do? It's kind of like a filter, right? So do you really need to know everything or see everything? Like, what sheet on the wall? Is there a wire here? Just like, I must be watching a lot of TikToks late at night. You ever watch those TikToks or whatever, where they show maybe a young woman who's quite well endowed, but then she's carrying a baby, and they're like, what color was the baby's shoes? And they're like, man, I wasn't looking at his baby's shoes. I was looking at baby mama's shoes. I was looking at her shoes, right? Because what does your brain do? It has to interpret, and just like it's also the same thing how magic works. Like, what do you think they do that corny thing when they're like, thinking Dave Copperfield goes, does that stuff? Because what are they doing? They're distracting you from what really is going on. And that's just your thalamus, gateway for sensory impulse, and does what? It kind of integrates the sensory impulse and kind of filters it, because you don't need to see everything. Anyone watched Man of Steel? Henry Cavill. Was Henry Cavill Man of Steel?
That was old. It's been a while.
Well, remember when Lex Luthor, right? Like he took off his helmet. Now he can't do anything because he now sees everything and hears everything. Which actually, I used to wonder, like, why does Superman, like, if he can hear and see everything? Or actually, my question was when I was younger, I was in catechism class, like that 1 week before I got kicked out, right? I used to wonder, like, if God knows and sees everything, won't he be annoyed? Because imagine, like, a couple of billion people going, hey, Jesus, do you think we can hit the Powerball this weekend? Right? Like, how does he filter all of that? Well, Jesus probably has a thalamus. And it does what? It interprets, and that's why he isn't listening to you. He's listening to, I don't know, Winds Radio, 10:10 a.m. Hypothalamus. The only thing we all know is what? Hypothalamus homeostasis. It's going to do what? It's going to do all the automatic stuff. All of it, right? And it links the two systems, nervous and endocrine, which are our two main communication systems, the fast system and the slow system. And that's the hypothalamus, very important. And the limbic system. Your emotions are also chemical and electrical, right? And your limbic system does what? And in psychiatry, we're very interested in what the limbic system and how the limbic system reacts to certain chemicals and hormones, because it has a lot to do with your feeling and your emotional responses. And think about it, because a lot of people's emotional responses are typical, right? And that's why when someone stands out, right, like when you look at a child on the autistic spectrum, Even if they're high on the spectrum, when you meet them, you know something's off, right? Even though they say all the right words, have you ever met anybody like that? Like they say all the right words, but something's wrong, right? And also many people with personality defects, because we're always looking into the limbic system, because even though they've been trained to say all the right things, like there's something a little off, and that's actually called precox or precognitive, and that's why trust your gut when you're in the ward. You feel a little bit off or you feel a little bit nervous, leave the room, get out of there, because that's part of your gut telling you what. And actually, that's a whole lecture I had in medical law and ethics. When you're asked to be doing something that may be legally correct, but it's making your gut feel funny, don't do it. Document it, don't do it. Bring it up your chain of command, because it's probably something what? Iffy. Because how many times I totally ignored that gut feeling, and I regretted it immensely. Because I always thought, like, if I don't do it, my boss will be upset, right? I won't get promotion or I won't get paid or whatever. But we are in a very ethical business, which is what the higher ethical standard. And we are in one of those kinds of businesses. Like, if I was a baker and I'm not ethical, so what? If I'm a banker, I'm not ethical, I'll probably get paid more. But here in healthcare, if you're not ethical, you can get fired for it. So that's why I'm so curious why you guys don't have a medical law and ethics class. I rechecked, you guys don't. It makes me sad. Brainstem. Now we're at the level of where? The base. Like when you look at the word brainstem, right? Stem of a flower is what? The base. So this is right before the spinal cord. And it's the connection. So you have midbrain, pons, and the medulla oblongata. Every time I read that, even though I went to medical school, I always think of Adam Sandler.
Yes. Yes.
I see how media contaminates the mind. So these are all the nerve tract fibers, and these are, again, we are now at the hindbrain, which is the what? Very, very basic stuff, the stuff that keeps you alive. And you look at here, and in medical school we call it when you look at it like this, we call it elephant's trunk for some reason. Yeah, they call it the elephant's trunk, memorizing all these little lines and stuff like this. But know that the brainstem, if you look at its position, right, you have all your higher function there. Then you had the midbrain stuff, but all the lower, very basic stuff is where? Deep inside. So what's important about it? Let's look at the pons, right? And the pons was that little, the little bulge, and we're gonna go over actual location, but the function is it's a relay. But the big thing that we need to know about the pons is what? Breathing. Your breathing has rhythm. So when you're learning your clinical skill sets, it should be like 1 to 3 or something like that. I forgot the ratio. But you see when someone breathes, it's what? Inhale. And then it takes a little bit longer to exhale, doesn't it? Like, so it goes like this. And it'll be what? Relatively regular. But if you have someone breathing like this, and having dyspnea, there's something up, right? So that's what? That's SOB, shortness of breath, dyspnea, right? And it's regulated. If it's odd, just know that if it's odd, there's no rhythm, then you might think what? It's a Poncine problem or a Pons problem. So think rhythm of breathing, Pons. Again, I'm looking at that, I'm thinking alligators. Medulla oblongata, right? We already know that now that's the area of ascending and descending fibers. Cardiac, vasomotor, and respiratory control. So it's not only the heart, it's not only lungs, it's also everything to do about the arteries, vasomotor. Arteries have pressure, right? And arteries have little muscles on it to do what? To squeeze when I need more pressure. And who controls all of that? The medulla oblongata. And then a whole bunch of reflexes. things that are for my protection, but I don't think about. So coughing, I don't think about coughing, I just cough. My body senses that there's foreign body or something in my respiratory system that doesn't belong there. So you do what? Cough. Sneezing as well. Swallowing and vomiting. And remember, swallowing and vomiting, they're the same side, they're the two different sides of the coin. Peristalsis is what? The food going down. Reverse peristalsis is the food going up, which, by the way, is also rhythmic. So all of that, think medulla oblongata, right? And you see injuries are often fatal, not often fatal. Remember, this is already the hindbrain. This is already the basic. You have any injuries there, especially a basal skull fracture that may cut or pierce that part, you're done. That's why I always highlight that one story, and it's been 35 plus years later, and her memory still affects me. Just imagine being in a park with your dads, just enjoying your little rollerblading life, and then in an instant, because of that area got pierced, you're done, right? And you can see why. It's all of everything. So Pons, think what? Rhythmicity of breathing, medulla oblongata, think all of the above. Your RAS, or your RAS, reticular activating system. Oh, now, anything that's reticular is like a complex. And it's like, like a Brillo pad. It's like all bunched up. And what does it do? Remember we talked about the other parts do filtering? Well, this is another filtering of information, but this is a filtering of actual information. Before, it was filtering of any sensory that comes in. This is filtering of actual files in your head. And your memory is organized via chemicals and electricity. And we're not quite sure exactly how, but we definitely know that the RAS deals with the way you sleep and the way you get up, the way you wake up, right? And of course, if I decrease the activity of the RAS, you go to sleep. I increase your RAS, you wake up. And the important thing about sleeping is, we already talked about it on 2 other lectures, that during rapid eye movement or deep sleep or stage 3 REM sleep, that is the only time your brain gets to do what? Organize all the files. That's why I always said since day one, if you have a choice between pulling an all-nighter and taking a little nap, take the nap. Because if you pull an all-nighter, those of you who cram, and the 1 or 2 of you, no, that was the other class. I don't think I have crammers here, because when you guys get stuff wrong, it's usually all over the place. But this is how you know. No, that's actually a better thing. This is have any of you cram, and if you have a person like me who does all the exams in order, like in chronological order, I do that on purpose. So that if you're cramming, you'll notice something like this. In a 50-item examination, 12, 13, 14, 15, and 16 are all wrong. Like you'll have 2 or 3 wrong in a row. That means what? That was a block of information from a chronological moment in time that you probably once knew, but since you crammed, and that's what cramming does, right? Remember, your short-term memory is only as short as this table. What happens if I keep on pushing things onto the short-term memory without practicing? Something's going to give and something's going to fall off the table. That's why some of you, when you come up to me when I give you, what you got wrong in the exam, I knew that. Why did I knew that one. And I go, well, you didn't at the time of the exam. No, I think I got it right. Can you check? Right? Week 1, how many? Like half of you. Can you check to see? I don't think I answered that wrong. No, you answered it wrong. It's right there. It goes at 5:39 p.m. It recorded exactly what you did. Because why? It goes, and the RAS has to do with that. It organizes all the information, the actual information, and it has to do with your sleep-wake cycle. And for us in this business, it's really hard to maintain. So think RAS, think a filter for actual information, and it has to deal with your sleep-wake cycle. So I decrease my RAS means what? Sleepy time. I increase my RAS, what will I do? Stay awake, right? And don't you think major depressive disorder does a little bit of both? Part of one of the tenets of major depressive disorder is what? I can't sleep. Doc, I can't sleep. I haven't slept in 2 days. I have nothing but thoughts. Or the exact opposite. Doc, my son, he can't get out of bed. He sleeps 20 hours a day. No lie. He gets up, has coffee, and then goes back to sleep for like a day. So both of those are what? Examples where the RAS is a little bit what? Off. Okay, and it's like down here somewhere, and you can see all of this. This is midbrain, right? And then you have your pons here, that little bump, the medulla oblongata, the little bump, and then the continuation is through the spinal cord. Now, how do you sleep? Those of us who only sleep a couple hours a night, right, probably only go through this, non-REM sleep. Your EEG or your electroencephalogram is, what do you call that? Let me go through this one thing and then we'll have a break. Your electroencephalogram is a machine that, anyone here has sleep study? They put the little things, yeah, what did they do, sir? Didn't they put stuff on your head? Right? And then they go, hey, take a nap here in this room in the hospital. And we dream, right? And what are they doing? They're looking, the way we sleep is patterned. And they're looking at the electrical activity. And remember, when you sleep, the electrical activity relatively goes increase. Right now, you may think, oh, no, I'm awake. My RAS is up. I'm awake. There's a lot of brain activity going on. No, it is not. It is when you sleep is when the majority of your brain activity ramps up. So I'm going to do this to make sure that I cut it in the right place. Round, around, around, round. Cerebellum. The cerebellum, if you recall when we looked at anatomage, we looked at this thing that was in the posterior lower section of the brain that was like this extra nub. And when you cut it mid-sagittally, it kind of looks like a tree or like a piece of broccoli. Well, that's called the arbor vitae. That's the white matter on it. And we'll see it clearly in a few. But what's important about your cerebellum is, again, another place for integration of sensory information, but what's really important is coordination of skeletal function and posture. Remember, like even if you are asleep, you have some relative posture, but then when you get into REM sleep, that all goes away. Think skeletal muscle activity, coordination, and posture. Another thing that there's parts of the cerebellum that if you look like the way I'm moving my hand, it's relatively graceful. So if you have something like Parkinson's, you'll have, you know how they shake and move around like that? Well, that's the lack of coordination of certain parts of your brain and your cerebellum. Your cerebellum starts to break down. You won't be able to coordinate your skeletal muscle activity. And we already know that there has to be coordination because upon flexion, your agonist has to be contracting and your antagonist, or your tricep in this example, has to be relaxing. And that goes all the way if you have a cerebellar issue. Spinal cord, of course, we know that it is the main stem of the communication from your brain to the outside world or to your peripheral nervous system. And the way it communicates with the outside world is through spinal nerves. Now remember, your central nervous system is your spinal cord and brain. Your spinal nerves are part of your peripheral nervous system. So if we look at this, here's your brain and here's your spinal cord. But there's going to be a whole bunch of nerves coming out through your vertebrae. And those are spinal nerves. They're not part of the the central nervous system. So if one of my spinal nerves breaks down, I'm going to have a problem in that particular area, but I can relatively survive. We already know this. Well, this is actually wrong. We already know the reflex arc. It does touch the central nervous system, but let's be more specific. It only touches the spinal cord. So you can write in your notes right here, spinal cord / interneuron, because does a reflex have anything to do with your brain? Do you have any thoughts when you're doing a reflex? No, you only have a receptor or sensory, then it goes through the interneuron in your spinal cord, and then interneuron. So inter means something that's in between. In between what? Your ascending fiber, which is an ascending sensory or afferent neuron or nerve cell. So there has to be a nerve cell where? In between. And that's your interneuron. And it isn't the central nervous system. It is actually your spinal cord. So think ascending fiber, spinal cord, interneuron, and then motor or effector. So these are things that don't require the brain. They're done automatically. And in the case of what we talked about, like when hot oil or you burn your hand, you actually move away from the danger before you even feel the pain. And that's because of this shortcut. Now, don't need to know about monosynaptic reflex, just know that what? A reflex, like patellar knee-jerk reflex, it's a survival thing, right? And in this case, maintain upright posture, because right now you're not noticing it, but right now your body's doing what? Right? If you videotape yourself standing, right? Will it be perfectly still? No, it'll be you doing this. Because just like driving on the highway, you're constantly making adjustments. Like last night, there was a lot of obstacles or whatever. They put a lot of cones out last night on 66, right? And you're constantly, I notice my hands is constantly doing what? This because, when you're in an open highway, you're not really paying attention to it much, right? But if you close yourself in one little lane, you start noticing the 1,000,002 adjustments you're making. And that's actually what's happening, even just you sitting in your chair. The withdrawal reflex, we already talked about that. Remember we showed the picture of the people running away from whatever scared them, right? Not one thing happened, a whole bunch of things happened. Not only did I take my hand away from the burning oil, what happened? When you get burned, your whole body moves away from the danger. And that's a withdrawal reflex. And of course, this is one synapse or very simple, but something like a withdrawal reflex requires what? A whole bunch of things, a whole bunch of innovations. And we saw that in those scared people, those pictures, right? So what happens? You have your sympathomimetic. Your eyes will go what? Really big. Your nose will flare up. Your mouth will open. And what will happen to your body? It will now it will now what? Face the opposite direction of what is scaring you. And that's a withdrawal reflex. And that's actually a good thing clinically as well. It's called guarding. When you're feeling around your patient's body or your patient's stomach, many patients, for cultural reasons, never want to tell you where it hurts, but you'll see something like this. If you touch something that hurts, someone will do this, right? They'll just move, their body will move ever so slightly away from what? The bad stimulus, right? So let's say this part of my right upper quadrant hurts, and I'm palpating, I'm feeling around, and I do this, the patient will do this. That's called guarding. Now, what is your patient reflexively doing? They are either feeling pain or anticipating pain. They're doing what? Look how it's not only just this part moves. Everything is moving what? To protect it. Right? So what do we see? We see a stimulus, right? Which is the blue. Then which is the orange. The orange. Then it goes up. Then you have an interneuron. Now, do you see the sensory? It's located where? in the back of the spinal cord, or the dorsum, and the anterior part is the motor. So what happens? I hit the patellar ligament, the ligament stretches, and then I sense it. And it tells my interneuron, hey, we're moving, or we have to adjust. So what does it do? Interneuron doesn't go to the brain, it goes right to the motor, and then the motor does what? Kicks. And that's exactly what's happening when you're standing still. Your body feels what? You're out of position a little bit, so it'll adjust. And it's making all these minor adjustments. And that's what a stretch reflex does. You'll also notice like if you get hurt, you notice it's harder to do what? Like even if you just hurt your head, it's harder to keep your balance because the signal is telling your muscle go do something. But let's say, for example, I got gout or I broke my leg or whatever, right? I won't be able to, adjust. And that's of course a muscular problem. If I have a spinal problem, you can now see, especially if I had a dorsal spinal problem, it's a sensory problem, isn't it? If I had a ventral spinal problem, then it's going to be a motor problem, isn't it? Or if I transect the whole thing, it's going to be both. Here's another look at it, and withdrawal reflex is a little bit more complex, so it's a lot of things going on, but it's actually the same thing. I have some sort of sensory, right? I feel that tack, right? How many of you, like, you don't even have to step on Lego, like full on. You just feel that Lego, like the piece. Those of you who have kids, you just feel that piece and you're like, ah, and you're already like on your way to falling down, right? Because you felt it, it's going up, it's going in the interneuron, and then see this little interneuron? It's where? It's inside there, and then, right, you saw the sensory is a dorsal of your spinal cord, and then what's gonna happen? It's gonna go out and make you do what? Like this, or, adjust your gait, not to step on that tack, or something more deadly like Lego. Cross extensor reflex, again, all of these things, it's all the same idea. You have some sort of sensory, and where does the sensory go? In the back part or the dorsal part, and then you have an interneuron, and then your motor is where? Okay. And you can see how it even crosses to the other side as well, because remember, if I'm having a withdrawal reflex, is it only my left side? Like, let's say I burn my left hand. Is it only my left side that's gonna move? No, I burn my hand. What's moving? Everything, left and right. So you can see how the interneuron even passes to the other side, so that you have left and right. And you see, based on the different reflexes, the doctor can figure out what nerve is messed up. So this pathway is L2 to L4. This pathway is L5 to S2, and this pathway is S1. Don't have to memorize that, but what do you need to know? That sensory goes up here in the dorsum, or the dorsal portion of the spinal cord. The interneuron is inside the spinal cord, and then your motor part is in the front part or the ventral portion of your spinal cord. Oh, and I forgot to mention, there's some things that are going to stimulate, there's some things you're going to inhibit, because doesn't that make sense? In order for me to do what? To flex my hand, what has to happen? I got burned here. Someone has to tell my bicep to do what? Flex. Someone has to tell my brachioradialis to do what? Flex. And what has to tell my tricep to what? Relax. You have your agonist, primary mover, you have your synergist, and then you have antagonist. Three entirely, well, not entirely, two sets of signals. One, this signal up here is going to tell me what? Contract, stimulate. And this signal down here is going to say what? Relax. Now, what happens to all these reflexes go awry if I just tase my patient? They'll, like this, they won't be able to move. And you guys seen taser videos, right? They do what? Right? They get all rigid and then they fall down. Can they maintain tone? No. Can you say coherent things when you get tased? No. So all the coordination gets what? Thrown out the window. And this is the same exact thing for seizure disorder. Peripheral nervous system. We already now know the cranial nerves and spinal nerves are what? They are from the brain, from the spinal cord, but they are not part of the central nervous system. So if you see cranial nerves, you think peripheral nervous system. You see spinal nerves, you think peripheral nervous system. The two subdivisions of the peripheral nervous system, we already mentioned, the somatic and the autonomic. The somatic, think what? Conscious activity. Soma means body. Skeletal muscle needs to be conscious, right? I'm consciously waving to you. I'm consciously taking a step forward. I'm consciously taking a step back. And look, I'm not doing the cha-cha. There you go. I'm consciously doing that. That is somatic nervous system. But what am I unconsciously doing? Autonomic nervous system. If I have fight or flight or sympathetic nervous system, I have no control over that, right? Your heart rate will go up. Your blood pressure will go up. Your pupils will be dilated. And of course, if you're parasympathetic nervous system, your pupils will do what? They'll shrink and constrict, thank you for the proper term, constrict, and your blood pressure will go down. Respiratory will go down. Endoneurium, perineurium, epineurium, and nice to know, peripheral nerves. If you looked at a nerve, look familiar? It kind of looks like a muscle. So didn't you ever wonder how you have the capability of picking up an egg and have that same ability with that same hand to do what? To squash it, to crush it, or to pick up a crate of eggs? And it's because just like the nerves, you have one nerve, but then they're all wrapped up with, you have one neuron or nerve cell, but it's all gets wrapped up. And if you look at this, it's kind of in the same fashion, zoom it in, as the muscle. Doesn't the muscle have a fascicle? Surrounded by an epimysium. Well, now it's found surrounded by an epineurium. Neur means nerve, right? You have your perineurium, and then the inside, endoneurium. We know that all of this yellow stuff is fat, and you could also see, look, the nerve needs to also be alive, as arteries and veins, so that the which support cell is going to connect this nerve to these arteries and veins. We already had Ali, right? He's the guy, he's that fat kid in the yellow shirt. We already had Epi Epperson, he's in that corner, he's guarding the pool. Goes, how about, did you see that guy? Goes, and he has a big star on his shirt. So what was it? Say it. Astrocyte. So he's got this big star on his shirt. Astro, star, right? So an astrocyte is the one that will connect this to this. Because remember, does the neuron or nerve cell do anything other than propagate a signal? That's all it does, is propagate or push the message in the form of electricity, which is your action potential, or in the form of chemistry, which is your neurotransmitter. And we already know the nodes of Ranvier, that's where we're going to have saltatory conduction so that the signal can go by very fast. And of course, the myelin sheath, that's all made up of fat or adipose tissue. We already know sensory, motor, some are mixed. We already learned that from the cranial nerves, that there are some nerves that do more than one thing. They not only sense something, they also conduct an impulse to a muscle or gland. There are 12 cranial nerves, and they're all located at the base of your brain. And here is a lovely picture, which you won't be responsible for, but I could ask you on the anatomage, hey, what's all these little, and remember they were colored almost white when we looked at the base of the brain, and they are all your cranial nerves. Your cranial nerves are numbered 1 through 12 in Roman numeral, and the homework that some of you did, I hope you got it from here, or you got it from someplace similar. So what are your cranial nerves? Cranial nerve 1, or Roman numeral 1, is purely sensory. And of course, what does olfactory mean? Smell. Cranial nerve 2, purely sensory. What does optic mean? I can see. Now, 3, 4, and 6 are motor. 3, 4, and 6, which is your oculomotor, trochlear, and abducens, they control your eyeball movement. You know when the doctor tells you don't move your head, follow this pen light, and then you move your eyes up, down, left, right, and diagonally? Well, the doctor is testing cranial nerve 3, 4, and 6. Now your trigeminal, you have, just know that your trigeminal is mixed. It has sensory, goes, and motor. And I want you to think what? Your face. Don't you feel stuff in your face? Right? This is how I remember it. When I do that, right, I feel my face. So that's sensory. And how many fingers did I just slap myself with? 5. So that's cranial nerve 5. And what am I doing? Masseter, muscles of mastication. So that's what? Motor. Motor, mastication, 5. I felt it on my face. So 5 is what? Mixed. It's sensory of my face and chewing. And we know chewing is motor. So that's mixed. So now we covered 1 through 6. 7 is just like 5. And it makes sense. Right? I can feel my face, but I also can do what? Have expression. You ever have any of you ever met anyone with no expression? It's kind of off-putting, isn't it?
Yeah.
Like, hey, how you feeling? I'm good. How are you? Right? That is one of the signs and symptoms of schizophrenia, right? Also, could it be a neurologic? If I have a cranial nerve 7 problem, right, or that part of the base of my brain, your patient will be talking like this. Hey, what's going on? Like you see, that's weird. Like there's no, because even if you're bored or whatever, just your face has to move a little. Now 8, right? We have 7. That's 5 with 3 little lines. That's 8. That's your vestibulocochlear. So when you look at that, vestibulocochlear, it's like 2 things. Your vestibule, which deals with balance, and your cochlea, which deals with hearing. And that's why when you have a really bad ear ache, your ear hurts, you can't hear, and also you're what? You're dizzy. So think 8, think sensory. Glossopharyngeal, 9, and look at the word. Glosso means tongue, pharynx means throat. So that has to be mixed because when I swallow, I have to move my tongue. And the sensory, in order to have a gag reflex, you got to be able to feel what? All the stuff that's going down your gullet. I don't know what's your gullet. Is it your food tube or your esophagus, or is it your pharynx? I don't know. I have to look that up. But you know this whole entire area here, right? You can sense it. Stick your finger down there. You'll feel it, right? And also, your tongue has to move, glosso, so that you can swallow. So 9, think mixed. Vagus, mixed, and see, this is weird. I always think of the vagus when dealing with your heart, but that'll confuse you guys. So vagus, think what it states here. More larynx, pharynx, and just like 9. But you'll learn when you do EKG, your vagus is really important regarding the impulses, your EKG impulses of your heart. 11, accessory. Do you notice 9, 10, 11, they're like all, what do you call that? Has to deal with your throat and stuff like that. But I always remember accessory as, remember we talked about when you're breathing really hard, you start using your shoulders and your back muscles, like when you breathe. Any of you ever see like someone with severe dyspnea? They're hunched over, like, You're trying to really breathe like that. Well, I always think of cranial nerve 11 as accessory. And when you're breathing like that, that's purely what? Motor. And last but not least, your hypoglossal. Look at like a medical term. Hypo means underneath. Glossal means tongue. So if you remember the cross section, the top part that you see is your tongue. That's like only a third of your tongue. The rest of it is where? It's down here. So it's this large muscle. So think hypoglossal. Think primarily motor. So when you're looking at this chart, you need to know, like if I say 1, 2, 3, 4, 5, you need to know the name, right? And vice versa. And you need to know if it's sensory, motor, or both, right? And then, of course, the name will kind of give it away. You don't need to know the divisions, but basically, that's it. The number, the name, the type, is it sensory, motor, or mixed, and kind of like an idea of what it does. And that's a typical cranial nerve question. Now, these are your spinal nerves. And if you notice, they're numbered just like your vertebrae. So I have 7 vertebrae, but I've got 8 nerves coming out of it. So it's C1 through C8. I have 12 thoracic vertebrae, so I have 12 thoracic nerves. Lumbar, 5. I have 5 lumbar nerves. I have S1 through S5, sacral, and of course I have 1 coccygeal nerve. Now, if you notice here, all the holes that we saw on anatomage, it is to facilitate all of these nerves coming out. And we also noticed this on anatomage as well. If we go into physiology and we clicked on, I think it was the 3rd or 4th picture down on physiology, it started coloring our patient in something called dermatomes. So what are these dermatomes? Dermat means skin. Tomography, tome means location. So when you're looking at this, if my patient has some sensory or motor problem with their cranial nerve 2, where most likely will the problem be? Up here somewhere, right? And if you see like cranial nerve 6, T1 through T12, of course, it'll be in their chest. Right? Remember I mentioned saddle injury? Saddle injury or motorcycle affects the back part of your coccyx, and we already know the coccyx has what? 5 cranial nerves in it, S1, 2, 3, 4, 5. I told you it'll affect S2, S4. So what's going to happen? Look where this man's penis is, S2, S3. So you have a saddle injury. What am I expecting? If I see S2, S3 problems, he'll have erectile dysfunction, he'll have a problem urinating, he'll have anything that has to do with that area. And you could look here, same thing here, right? He's also going to have, if you have a sacral injury, he's also going to have a problem with defecation and controlling any of that. Because remember, right? What's the tube back there? That was your rectum. And then you have, oh no, why do I say remember? I didn't go over that yet. We didn't go over GI, right? No. Well, know that you have sphincters, right? And sphincters are just circular muscles. Some of them you can control, that's skeletal, and some of them you can't. Well, we know that I can kind of semi-control this hole right here, right? But if I've had a sacral injury or a coccygeal injury, can I control any of that? Nope. So will my patient like wet themselves and defecate themselves? Definitely. So you can see how clinically relevant this is, not only for neurology, but for, just for anything, knowing that if the injury matches up to a dermatome. And again, back to what neurology does all day, every day, it's called localizing signs. You look at what are the problems of my patient, and then we can kind of trace it back to a nerve, to your spine, to a piece of your brain, and then of course, to a dermatome. Autonomic nervous system, we already went over that. Sympathetic and parasympathetic, fight or flight, rest and, I should use rest and digest. That's a better way to put it. I always say feed and breed. Yeah, because we're talking about sexual, so yeah. I'll use feed and breed forever. Who am I kidding? So sympathetic, So if a drug has sympathomimetic effects, that means it's going to mimic what? Being either really scared or being really angry. And of course, parasympathetic would be the exact opposite. Last but not least, lifestyle changes. We have apoptosis. Your brain cells don't live forever. But remember, if you keep on using them, the more of them will need to live forever because, not forever, but for a longer period of time because you need them. You have considerable brain shrinkage over a lifetime, some more than most, due to lifestyle, right? If you're a drinker, that number will increase. If you have traumatic brain injury, that number will increase. What else is important? Oh, this is another thing. And this is also another theory regarding major depressive disorder. My mother has a theory that it's what she says is it's natural to be depressed when you're old. That's a quote. And she's actually not saying it to be facetious. She's saying it because we know that there's a significant decrease in the number of neurotransmitters, right? And of course, there are neurotransmitters that lead to your mood of happiness, and there are neurotransmitters that lead to a mood of depression. So just think of it as a balance, right? So if all the neurotransmitters that make me happy start going away, what will predominate? All the neurotransmitters that make me sad, right? So, but again, we already talked about techniques and how to get around that. Also, action potential. Propagation, I believe it's way more than that. If you recall when you were younger, fast were you, right? I remember I ran the 50 in 5.8 when I was in high school, right? And now I can't run, but even when I did run, 50 meters is like really long, and I could take a good 10 seconds trying to run as fast as I could. Because why? The action potential as you get older will be slower. And of course, memory, slower responses, slower reflexes. Now, here is a really clinically relevant part. Of course, let's say you have a patient, and now our patients, the graying of America, we have a lot more patients greater than the age of 80, 85. 85 is one of those magic number cutoffs in internal medicine. And risk for falling. That's also a thing that I believe in your next set of classes, when you start doing assessments on your patient assessments, remember, your job is what? Direct patient care. That means keeping my patient safe when no one's around. And nowadays there's brilliant stuff. I think I mentioned it in Inova. Inova has an algorithm. Let's say you guys did all your charting and did it really well. You put it in the electronic medical records, right? It kicks back a program giving me a percentage on like a score on whether this patient's going to fall or not. And if this patient is a higher risk, guess what? I have you, the nurse, visit my patient more often than I normally would. Because typically I usually send the nurse in to monitor my patient more often if it's a cardiovascular problem. But now we also have to consider what? Are they a fall risk? There's also other algorithms for wellness. Because remember, we're looking at my patient holistically, right? So let's say you have a patient that's lonely, they don't have family in the area. What should you do as a nurse? Visit them a couple of times extra. Or, while you're going your rounds, you just visit, go, hey, bye. Just do that. Good? Yeah? Huh? Yeah, you're good, right? So great. And then just go a little bit. Especially in my high risk, I'm always doing that. Nurse, check. She's good. She's breathing. She's good. Mrs. Jones, you still breathing? Good? Okay. Right? I'm busy, but I did what? Making a little joke, make it, there's my dog there. Okay, cool. Right? Because what am I doing? I gotta, also, if you're really into it, years ago, I used to send some of my nurse candidates, there was a reading program. Because remember, when you get older, can you see as well? No, right? And many of them love reading, and they get really bored of the recorded books. They like someone to read to them. But the program was crazy because it asked 30 hours of my students, and not many, who has 30 hours? I only had a couple of students do it for a couple of weeks. But it's really nice because many of these patients, those of you guys know in assisted living, they're very lonely. They don't, there's not a lot of interactivity, right? Reading to somebody for an hour and then sharing your little thoughts on the book, like, oh my God, that's crazy. I didn't know he loved her or whatever, right? Again, we're looking at our patient holistically, because if my patient is depressed, or how well are they going to recover? Right? If my if my patient is bored, how often do you think they're going to try to get out of that bed? And then they get out of that bed, they fall. Whose fault is that now? It's not her fault. It's your fault. It's my fault, right? And of course, changing the sleeping patterns. Oh man, I love sleep, but there are times, like, especially if I binge watch something, or if something captures my interest, I'll be up all night on YouTube looking it up. Like the other day, I wanted to know about what are the best buffets in Ocean City, Maryland. I was up for an hour past my bedtime just looking up stupid things. When I was younger, I could go to sleep like, boom. Now, like, since we're all night birds, when you guys go home, well, you're probably exhausted from a whole day of work or whatever, and you just pass out. Me, I mill around the house and I look at stuff. So that's chapter 11. That's the second half of the neurology portion. And I am now going to stop recording and get of course,